Hello, future doctors. How are you all? Welcome back to MedStep's Internal Medicine Series, episode 9 by Dr. Anand. So today we are going to discuss very high yield topic, very important. If you are doing any internal medicine department or general surgical department or whatever you are doing or OPD or you are working like intern or clinical physician. So most commonly we can see one condition we called ascites. So today we are going to discuss that important topic. Okay. So without time waste, let's begin. Good. Ascites. What is ascites? So ascites is the abnormal accumulation of free fluid. Yeah, abnormal accumulation of free fluid within the peritoneal cavity. So um, normally around around 50 ml of peritoneal fluid you can see. If ascites means become clinically detectable when greater than 1.5 liters of fluid accumulates, then we call that is ascites. Okay, but why it's important? This is the main peritoneal fluid will help to lubricates abdominal organs, and it will help to reduces friction, and it will help to prevent adhesions, and it contains macrophages and immune cells. Okay, so that's why this is the main peritoneal fluid is very important. Like normal cases less than 50 ml peritoneal fluid you can see, but in ascites greater than 1.5 liters you can see. So if you are seeing means most common cause worldwide of ascites, that is liver cirrhosis. I already discussed this liver cirrhosis topic. So if you didn't watch my this episode 7, you can go and watch. So you will get more idea about liver cirrhosis. So the we have some other causes also can cause ascites like malignancy, heart failure, or tuberculosis, pancreatic diseases, or nephrotic syndrome. So these are the main pathological conditions can cause liver cirrhosis. Okay, so we have some causes can cause this ascites. So the causes we can divide into two different types. One is transudate and exudate. So in this transudate, causes like portal hypertension will come, and hepatic veno-occlusive diseases, portal hypertension because of liver cirrhosis, Budd-Chiari syndrome, and cardiac failure, and Ming syndrome, and consecutive pericarditis. So these are the things will comes in transudate. In exudate, we can see cancer like metastasis or primary carcinomatosis, infections like including peritoneal tuberculosis, nephrotic syndrome, lymphatic obstruction, and cirrhosis. So these are the main factors will comes in exudates. Okay, so we have some causes like hepatic causes. Hepatic causes like liver cirrhosis is the most common, and alcoholic liver diseases and hepatitis will comes. Next, another cause that is cardiac. Cardiac causes means we can see congestive heart failure and constrictive pericarditis. Next, we have another cause that is renal. In renal, we can see nephrotic syndrome. We can see. Next, we can see that another one that is malignancy. Malignancy, uh, the malignancy main cause we can say like ovarian, gastric, and pancreatic and liver metastasis. Next, we can see that is infection. In infection, we can see tuberculosis peritonitis. Next, another one we can see pancreatic causes. The pancreatic causes like acute or chronic pancreatitis. Others causes also we have that is Budd-Chiari syndrome and hypothyroidism. These are the main causes we can see will cause ascites. Okay, so next we can see here that is pathophysiology of ascites. The pathophysiology of ascites you can see here. When first of all the patient will get liver cirrhosis. Because of liver cirrhosis we can see portal hypertension. In that portal hypertension, before that the patient will get hydrostatic pressure will increase more. Why means because of this transit the fluid will accumulate as a transudate and exudate causes. We already discussed that what are the causes will comes in transudate and exudate. So here what will happen, the splanchnic vasodilation we can see. Why? Because of this portal hypertension. Okay, the splanchnic arteries will causing reduced arterial blood flow. Okay, so it will affect the The splanchnic vasodilation because of nitric oxide. Then after it will reduce effective circulating volume. Then after it will activates the renin angiotensin aldosterone system and sympathetic nervous system and ADH. It will help to result in sodium and water retention. Okay, then the patient will get hypoalbuminemia. Then it will cause fluid leaks into the peritoneal cavity. At last, the patient will get ascites. Okay, so this is the main pathophysiology will cause ascites. So why this thing is happening? Because of um, Starling forces. Starling forces means it's like fluid movements depends upon hydrostatic pressure will increase and oncotic pressure will reduce. Starling Starling forces we called. Why the Starling forces? It will increase hydrostatic pressure and reduces oncotic pressure. Okay, and we can see capillary permeability and we can see lymphatic drainage. So this ascites develop when hydrostatic pressure will increase, when the albumin will decrease, then the sodium retention will increase. So the fluid will enter into the abdomen. Okay, so we discussed causes and what are the risk factors we have for ascites means we have some risk factors. The risk factors like alcohol abuse patient and chronic hepatitis like B and C and NAFLD non-alcoholic fatty liver disease, obesity, diabetes mellitus, portal hypertension, liver cirrhosis, malignancy, tuberculosis, heart failure. So these are the main risk factors. Okay. So whenever patient have ascites, how to do that grade means if patient have ascites, we are going to divide into three grades: grade 1, grade 2, and grade 3. In grade 1, this classification will help to um, assess the volume of the peritoneal fluid and the ascites we can check. In grade 1, we have to do ultrasound is enough for mild cases. In moderate cases, a patient getting visible distension is the main moderate case. In large case, we can see tense ascites. Okay, large and tense ascites we can see. Next one, clinical features. In clinical features, we can see some sign and symptoms. So first of all, we can see progressive abdominal swelling. Progressive abdominal swelling or fullness. So because of the thing, we can see weight gain, abdominal discomfort, and early satiety and breathlessness we can see, and fatigue and reduced appetite and pedal pleural effusion we can see, and peripheral edema may also be present. Okay, so in signs we can see we can do some signs. For checking signs we have to do physical examination. What it means, when we are seeing patient, we can easily find out moderate and severe case if patient have ascites, but we have to do physical examination. In physical examination, when we are doing general examination, we can check distended abdomen, bulging flanks, and everted umbilicus because of that tense tension building inside the abdomen. Next, dilated abdominal veins we can see. Next, we can do percussion. In percussion, we can check shifting dullness. Okay, and some other signs of underlying cause may also be present, like shifting dullness and fluid thrill in large ascites. Next, we can see some associated findings like jaundice, spider angiomas, pulmonary erythema, and hepatosplenomegaly. Okay, so in physical signs, in mild cases, we are not going to see any obvious signs. In moderate cases, we can see flank fullness, shifting dullness. In massive cases, we can see fluid thrill, tense abdomen, umbilical hernia, and respiratory distress. Next, we can do some diagnosis. In diagnosis, we have to check with blood. In blood, we have to do some lab test like um, CBC and liver function test. In liver function test, the serum albumin is very important. The normal serum albumin we can see 3.5 to 5.0 grams per deciliter. Okay, in liver function test, we have to check um, the total bilirubin, ALT, AST, INR, and kidney function test also we have to do check for creatinine and electrolytes like sodium. Okay, and CBC also we have to check hemoglobin. Okay, so this is the main investigation we have to do. Then after we can do imaging. In imaging, we can do ultrasound to detect fluid greater than 100 ml and liver cirrhosis, portal vein diameter, and splenomegaly and tumors. In CT abdomen also we can do, if it's a CT abdomen for ruling out malignancy, pancreatitis, and tuberculosis, it will help. So next we can do ascitic tap, also known as diagnostic paracentesis. So every new onset ascites should undergo paracentesis. Why? Because this ascitic fluid, we can do analysis with the appearance, albumin, total protein, and with the cell count and culture or cytology. Or if pancreatic means ascites means, we can check amylase. If ADA, if you're suspecting TB, we can check ADA. Okay, so next you can see here this ascitic albumin. It will help to differentiate between transudate and exudate cases. If greater than 11 means that is transudate exudate cases. If less than 11 means that is transudate cases. Okay, so and we can check the WCC count, gram stain and culture we have to do. With neutrophil count we have to check greater than 250 cells of polymorphous. Next, it will suggest spontaneous bacterial peritonitis if it's a neutrophils more than 250. Cytology we have to do for malignant cells and amylase for pancreas. We discussed already. So next we have one criteria we call SAAG criteria. The serum ascites albumin gradient. It is formula to help to determine cause ascites. So the formula will be like, the formula is here. SAAG equal to serum albumin minus ascitic albumin concentration. Okay, so serum albumin minus ascitic albumin if you are doing means the patient will get some value like greater than 1.1 grams per deciliter. So in SAAG criteria, in SAAG criteria, if it's greater than equal to 1.1 grams per deciliter, we have to suspect portal hypertension. Okay, if less than 1.1 gram per deciliter means we have to check non-portal hypertension. Okay, so now if it's high more than 1.1 grams per deciliter means portal hypertension, right? This portal hypertension, the main causes we can see cirrhosis, heart failure, and Budd-Chiari syndrome, and we can see portal vein thrombosis. So these are the main causes of greater than 1.1 gram per deciliter and portal hypertension. These are the main causes. Next we can see that is less than 1.1 grams per deciliter. The main causes will be like, if low SAAG means TB, malignancy, pancreatitis, and nephrotic syndrome we have to suspect. Okay, so now how to do we did already that investigation. So for diagnosis, always we have to approach with diagnosis is based on clinically, like history taking, then after clinical examination, ultrasound, and diagnostic paracentesis and SAAG interpretation, and we have to know that the cause evaluation. Then after we have to do management. So in management, the main goals to treat underlying cause and to reduce portal pressure and to remove excess fluid and to prevent recurrence and to prevent complications. So in management, we have to do some sodium retention. So salt restriction, less than 2 grams per day sodium and 5 grams 5 grams salt per day we can use. And we have to do fluid restriction only if severe hyponatremia, and we have to stop alcohol completely. Okay, then after adequate protein intake we have to do, and daily weight monitoring we have to check. Then we have to avoid NSAIDs. You have to avoid NSAIDs and vaccinate against hepatitis where appropriate. Okay, so we have to treat underlying cause. Then after bed rest and fluid and salt restriction is very important. Next, we have to go with diuretics. What it means? Diuretics means first one spironolactone. Spironolactone means aldosterone antagonist. We can use 50 to 100 milligram per day orally once per day. We can give long term. The main indication for first line drug for cirrhotic ascites, and whenever we are giving spironolactone, we have to check potassium levels. Okay, so next one, furosemide. Furosemide can be also we can add. Furosemide means that is loop diuretics. We can give around 40 to 160 milligram orally or intravenous once daily for long term, and we have to add on therapy. Okay, we have to add on therapy. Next, we can see here that is albumin. So we can give, okay, whenever patient doing any if patient did any paracentesis, yeah, if patient did paracentesis, we have to, if patient have 10 ascitic, we have to use, if patient have we have to give albumin around we have to administer albumin, because whenever you are doing paracentesis, we are taking out total albumin, so patient will get rapid symptomatic relief, it will reduce. So we have to give albumin. Albumin is like plasma expander, 8 6 to 8 grams per liter we can give. Ascites, we have, after removing ascites intravenous, we have to give during large volume paracentesis single dose, and we have to prevent circulatory dysfunction, and it's essential if greater than 5 liters removed. Or we can use midodrine also. Midodrine is the alpha 1 antagonist, 7.5 to 12.5 milligram. We can give orally 3 times per day, individually for preventing refractory ascites to improve blood pressure. And cefotaxime, we can use cefotaxime, third generation cephalosporins 2 grams intravenous every 8 hours, 5 to 7 days. If you're suspecting spontaneous bacterial peritonitis, we have to start cefotaxime, and we have to start promptly if you're suspecting spontaneous bacterial peritonitis. Or you can start with norfloxacin and ciprofloxacin. Norfloxacin, ciprofloxacin is a fluoroquinolones. As per local protocol, orally we can use once daily for long-term prophylaxis in selected patients. Okay, and it's used only where appropriate and according to resistance pattern. Okay, so we have to choice depends on local antimicrobial guidelines in based on that place. Okay, so whenever patient coming with in management cases, we can start with first line drugs, spironolactone and sodium restriction. If inadequate response, then we have to add furosemide. In second line management, we have if patient have large volume paracentesis, we have to do albumin infusion, and we can use in hypertension patients, we can use midodrine for selected patients. In alternative cases, if always the patient getting like a refractory ascites, then we have to start transjugular intrahepatic portosystemic stunt, means tips. So these tips we can use and repeated therapeutic paracentesis. Okay, then we have to treat spontaneous bacterial peritonitis accordingly with antibiotics. Okay, and along with that, we can in severe cases, if MELD score is more, then we have to start liver. We have to do liver transplantation. So here, how to treat this ascites based on grades. Grade 1 means we have to observe, we have to treat the cause, and we have to do salt restriction. In grade 2 means we have to do salt restriction, spironolactone with or without furosemide. In grade 3, we can do therapeutic paracentesis, albumin infusion, diuretics, and we have to consider tips, and we have to evaluate for liver transplantation. So we have to we have to do some refractory ascites. The main refractory ascites, the ascites that can't be mobilized or recurs rapidly despite maximal medical therapy. The management will be like we have to do serial paracentesis, albumin, tips, and liver transplant assessment. Okay. So the main complications with ascites, the patient will get spontaneous bacterial peritonitis, hepatorenal syndrome, hepatic encephalopathy, umbilical hernia, and respiratory distress, electrolyte disturbances, hyponatremia, and malnutrition. So for follow-up, what we have to do? We have to check daily weight, abdominal girth we have to check, and blood pressure, renal function, and serum sodium, serum potassium, and liver function test, signs of infections, and response to diuretics. So in exam point of view, the doctor can ask if you're doing internal medicine clinical rotation. End of the rotation, the doctor can ask some questions in exam in ask settings. The most common cause of ascites, that is liver cirrhosis. The first investigation of ascites is the ultrasound, abdominal ultrasound. Every new onset ascites needs diagnostic paracentesis is very important. The most important test is SAAG we have to do. High SAAG means it's related to portal hypertension causes. If it's first line diuretics means if we can use first line diuretics for preventing um, ascites. Large volume paracentesis to give intravenous albumin. And we have to refractory ascites, we have to consider tips or liver transplantation. Okay, so these are the things. If you didn't subscribe my channel, you can subscribe if this video is helping you. If you want to ask any questions or any queries, you can message me in comment section, or you can message in comment section. Along with that, if you are not following me, you can follow through Telegram MedSteps Medical Education, in Instagram Dr. Anand Jana. So we will meet in our upcoming internal medicine series episode. So till the time, I'm signing off. Dr. Anand Jana. Take